Good evening everyone, and thank you for joining our online open event for health and care professions. Tonight I'll be joined by tutors Karen, Maria, Elvis and Adam. We'll be discussing the impact of integration to healthcare services. We'd really encourage you to get involved and ask questions on the topic, as well as any other questions that you may have in mind. If you have any questions, you can pop them in the Q&A box. It's just to the right hand side of your screen, and our team will do our best to get through these questions for you. So I'm now going to hand over to Adam and we're going to get started. Thank you.
Okay, good evening everybody. So the topic that we thought would be very current for us to have a look at in terms of a discussion was the whole subject matter of integration in health and social care, and also, you know, that's throughout the life course. So obviously that applies as much to children and young people services as it does to adults. Now, as I'm sure a number of you are aware, since the Second World War in the UK, we've essentially had a divided system whereby there's been what we call healthcare, which is provided by the National Health Service and other related bodies.
Adam, you are muted.
Thank you, Elvis. That wasn't a very good. It was a brilliant opening speech I just did. I'm sorry you were party to that. So right, I will start again. Sorry about that. I do apologise. Okay, so the subject that we wanted to sort of have a look at in terms of our discussion tonight was really about the whole issue of the integration of health and social care throughout the human life course, and how that's ultimately being supported and underpinned by lots of government strategies and policies, particularly so in the last sort of 20 or 30 years or so. And it's really about assessing how far that integration has actually happened based on the available evidence and research that we have, and also you know, I think it's about discussing some of the future plans that the government have got under things like the NHS long-term plan. Also, I think looking at you know, our own experiences, because ultimately we all use health and social care services ourselves, whether that be GPs, dentists, or whatever else that might be, whether it could be hospital, primary, secondary care, or early years settings like childminders and nurseries and so on and so forth. So I think the idea really from my starting point is that I think it's been recognised by a number of different government agencies, commentators, professionals, organisations like the King's Fund and the Health Foundation and so on and so forth, and also the key policymakers, that the division that has existed in the UK since in the post-war period, where there's been a distinction between healthcare and social care, is really a false distinction, because ultimately I think when we're looking at ourselves as individuals, when we're looking at people who are living out there in society, living within a number of different health needs and health conditions, because as we know, we've got an ageing population with increasing numbers of people now living with what we describe as comorbidities. The care and support that those individuals need tends to be a lot more complex and multifaceted. So to define a person purely in terms of health needs or social care needs is really essentially a false distinction. And historically, it would be fair to say that in the post-war period, I think some of the government policy that was initiated at the time of the introduction of the welfare state and the National Health Service, it made this distinction between healthcare and social care. Healthcare being something that is free at the point of delivery, provided by the National Health Service, and obviously more latterly, increasingly so, by private organisations. And when we talk about healthcare, we think of it in terms of the prevention, detection and the treatment of illness, don't we? Whether that be physical illness or mental illness. Social care, on the other hand, has been predominantly funded and commissioned through local authorities. Again, when we look at social care now, it's increasingly very much what we call a mixed economy of care, where it might be provided by the statutory, private, voluntary and independent sector. And again, when we think of social care in terms of what it's generally thought to cover, it's things that mainly to do with supporting people with activities of daily living, you know, promoting independence, promoting person-centred ways of working, you know, enabling people to function as independently as possible. And obviously, when you think about the number of different professions that we've got out there, increasingly we're seeing a crossover. And I think really when we're talking about the whole context of integration, I mean, there's a number of policy documents that support the whole concept of integration, because it's something that a lot of the research by organisations like the King's Fund, I think there's been research done by the Audit Commission, is that integration of health and social care is seen as the main mechanism by which we can achieve better outcomes for individuals. We can also make sure that people's experience of care and support is better, that people don't fall through the gaps, that we look at people more holistically. We focus more on prevention, we focus more on early intervention, we focus on how we can better safeguard people, because obviously within the children's context, we've got the Working Together to Safeguard Children framework as well. And obviously Every Child Matters, and all those frameworks emphasise the importance of health and social care working together more holistically to deliver more person-centred services to meet the needs of the population. And obviously there's been a lot of pieces of legislation that have been passed, a lot of strategies such as our shared commitment strategy from 2013, where leaders of the NHS, local governments, Care Quality Commission, Social Care Institute for Excellence, other organisations basically came together to reinforce their commitment to integrated working. And obviously that was predated by legislation such as the 1990 Community Care Act, and it's also been supported by other frameworks like, as I alluded to, Every Child Matters, the National Health Service Acts, of which there've been a number, the Health and Social Care Act of 2012 and the Care Act of 2014. Now, in terms of the general research, from my perspective, what's been done into health and social care integration, although there's a very substantial body of evidence out there that's been collated and gathered together by organisations such as watchdogs like the King's Fund, for example, I think the general view on integration is, although it's something that is supported and underpinned by a number of government policies and procedures, the actual scale and pace of progression towards meaningful integration of services, both at strategic level and also operational level, whereby we as community members and patients and service users, whatever you like to call us, come into contact with services, that integration isn't happening necessarily at the scale and the pace that it should be. Okay, and obviously that presents a number of challenges for us. Because it means that services that we deliver and receive are not necessarily as efficient as they could be and they should be. It also means that there is still that potential for people to potentially fall through the gaps in the system. It also means that, you know, we've still got potential barriers between people working in different professions where they have like different performance regimes, different terms and conditions, different standards to work towards. So there's a number of potential barriers and things that get in the way. That said, I think what the overwhelming evidence suggests is in the areas where integration has been done well and been done effectively,
there's a lot of research done by organisations such as the Care Quality Commission, which again they've alluded to in their most recent State of Care report, is that in places where integration is happening and it's embedded, like I said, at leadership and operational level, it's having a massively positive impact on outcomes for people living in those localities. And again, it doesn't matter whether they're children, young people, or whether they are sort of octogenarians or even people even older than that. Those services are delivering more effective and more efficient outcomes for the people that they support. In addition to which, one of the key drivers behind integration now, given that we have a population which is increasingly aging with comorbidities, is that we have to think about the sustainability of the health and social care system into the future. We know that there's a lot of key challenges and problems that we face at the moment. For example, levels of childhood obesity. We know there's issues to do with poverty. We know there's issues that are probably a lot broader, if the truth be told, in terms of things like health inequalities, where we really need to focus on making sure that every child has the best start in life, and that support and that advice and is provided to people throughout their life course to enable them to live the best possible life that they can, to make the right lifestyle choices so that they can obviously maximize their potential in terms of their, life opportunities, in terms of their quality of life, and obviously in terms of their longevity as well. So I'd just be interested to hear the views of other people on this particular subject matter, given that I've done a fairly lengthy preamble there. So I'll hand it over to you. So if anyone else would like to make a contribution or share their views.
Got a couple of questions which might direct it. So I presume one here would be a good one for Karen, who's over more of the kind of education and childhood studies side of things. But what is the real impact of disparity in education when it comes to healthcare services?
At the moment with education, it's not affecting it in too much, with too much detrimental value towards schooling. There is issues around funding, and especially with the Marcus Rashford doing the school meals, is the only issue they are having at the moment is providing the school meals during the school holidays. That's one of the main issues at the moment. So.
And then as a bit of a follow-up question, Karen, which, and again, might be back to you guys, Adam, Elvis and Maria as well, but how does education influence development and result in poor health? Because Adam, I know you touched on kind of poverty and how that kind of plays a bit of a role, but obviously education also comes into that as well, doesn't it?
Yeah, very much so. I mean, I think if you think about some, there've been some real tangible examples of things that have happened during the COVID lockdown, for example, whereby, I think it was the case that, there was a considerable percentage of private schools were continuing to deliver online lessons during the time that only a very, and at the same time this was happening, only a small number of state schools were delivering the same comparable level of online lessons, which suggests that there's something of a mismatch there. We know things like educational achievement. There is something which sociologists refer to as differential educational achievement. And again, it's noted that people from lower income backgrounds tend to succeed less in education than their more affluent counterparts. And again, that's down to a whole host of factors. It might be the fact that the schools in the more affluent area tend to be better resourced based on a lot of the research that's been done. It might be because, parents are better educated, they're more able to support with learning materials, such as IT access to IT things. The children might have better access. I think when we're looking at things like educational outcomes, I think what we know about health, education, development, life opportunities more generally, it's not down to one single factor. It's down to a number of coexisting factors and the whole interplay of those things. And that means that ultimately, you know, when we're looking at children and their educational achievement, that again, what all the available evidence is telling us, the lower down the socioeconomic pecking order that you're on, your opportunities are, you know, likely to be different from those from somebody who's born into a more affluent household, whose parents can afford better food, better housing, better access to, you know, they can pay for things like personal tutors, private education, make sure that the child's got all the up-to-date IT facilities and on all those other educational things that they'll need in their learning journey.
Yeah.
I think that's
that's quite yeah. I think that probably goes on to almost a wider question, doesn't it, of kind of like how far does this integration actually extend? You know, does it include justice? Does it like the how many different sectors would actually really need to be involved for this integration to really support each individual? Might be a rhetorical one.
Manchester at the moment. That's a very good point, because within Greater Manchester at the moment, we have something that was put in place in 2017. This concept called population health, and what the whole concept of population health is based on, it's the idea that the things that ultimately determine whether a child succeeds in education, a child lives a long and healthy life, is ultimately determined by things beyond a lot of the things that we consider traditionally as health and social care services, you know, whether they be for children and young people or for what we really need to do in terms of maximising health and opportunity across population. And as we know in Manchester, particularly in the central region, we have in the UK today, and it's a real concern for us, particularly because of, you know, issues like poverty and homelessness and substance misuse and, you know, obesity and heart disease, etc., tend to be worse in the inner city areas, and obviously those things are very often coexisting with other issues as well, like poverty that I talked about. So population health and the strategy that we now have in Manchester is really about working health and social care services working together, A, as an integrated unit, and also B, working together with industry, working together with you know, looking at generic services like transport, housing, you know, working with businesses, because obviously a good economy means there's job opportunities, which means people are like to secure an income, which means they can afford better food, you know. So all these things all closely interlinked, they closely relate, they're all very, very much interrelated in terms of determining a person's life choices and outcomes. And I think, you know, population health, linking together education, transport, housing, local government, national government, the justice system, policing, whatever you want to think about, education, it's all got to be conjoined really in terms of delivering an overarching strategy that you know is ultimately you know has clear leadership. And I think the population health plan that we have in Manchester now, you know, sets some really good positive targets and priorities in terms of ambitious targets, and whether or not those things will ultimately be realised, we don't know, because, you know, obviously delivering better quality services to people, better education to people, it costs money, doesn't it? We all know that, and that's something that, you know, as we've seen with the recent COVID lockdown and the discussions that are very much ongoing with Mr. Johnson and Mr. Burnham, is the issue of resourcing is very much a hot potato.
and it's likely to be so long into the future.
Yeah, and that probably comes on to a nice point there. A question we've also got is how much onus should be put on the individual versus the institution?
No, I think that's a very great point. I think that's an excellent point, really. I mean, one of the things that we study on the programme is we look at we do modules on health inequalities, public health, and also, you know, looking at strategies which are all about building resilience and well-being amongst individuals and communities and that sort of stuff. I think it's a bit of both, really, because I think there's always that thing. I think agencies, you know, whether they be education, whether they be early years, whether they be NHS, local authority, private, voluntary, independent, we can only take people so far. We can only, you know, you can only advise somebody to give up smoking. You can only advise somebody to drink within what we would deem to be healthy limits. Ultimately, it does come down to the individual as well, because people, you know, for all the the best intentions of the world of the government and government agencies, people will make their own choices. And again, there's a whole range of reasons for that. It might be because of the, you know, the socialization process they've gone through. It might be because of their own lack of willpower. You know, again, it's a very, very complex thing that we need to look at. But yes, individuals, you know, have to take some ownership and some responsibility for their own health. And again, we've seen examples during the current COVID lockdown that some people have decided to completely flout the law, haven't they? And they've decided to organise illegal raves and parties and things like that we've seen locally in Manchester. So yeah, I think it's about individuals and organisations working together in partnership.
Yeah, and I guess obviously you've mentioned the current situation with COVID as well, but I guess that probably tails back especially to kind of what your thoughts are on what the long-term impacts might be to the healthcare and system, the education system, all those kinds of things. Because I mean, I don't know how long we know that this is going on for, but I think it's clear it has raised some issues, hasn't it, already, about like you said, digital poverty and various other things as well.
Well, I mean, I don't know if anybody else has got any views on that. I think it might be nice for me to let somebody else.
You're doing such a good job, Adam.
I know.
Shall we come to you then first, Karen, for your thoughts on that, and then we can go around and speak to Elvis and Maria as well, shall we?
What was the question? I've lost it
so
now.
Yeah, what do you think the long-term impacts on kind of the healthcare, and obviously probably more in your case the education system, will be post-COVID?
A lot of catch up, a lot of doubling up on sessions for the youngsters to allow them to get back to where they should be in their developmental age and stage of educational just where they should be on the educational side of it, because obviously they've lost nearly 12 months of learning now, and practitioners themselves are finding it hard to do the catch up. So they are starting to employ a lot more teaching assistants to pick up these roles of teachers. So again, hopefully in the coming years, there will be some more teacher roles, especially probably next year, where they're looking at probably employing a lot more newly qualified teachers, because they're just not managing with the backlog of educational demands at the moment.
Yeah, shall we come to you next, Maria? What are long-term impacts?
I was just thinking about the complexities really about health and how it impacts on all of us. I was thinking about gender differences, also disparities between social stratification like class, socio-economic status. And I also thought about differences in relation to ethnicity. That's something that's not been discussed much, as well as cultural. As well as cultural and lifestyle differences. And let's not forget age-related differences as well. That's a big thing. The environment and of course the influence of media and technology. So I think overall it's very, very complicated to really put a finger on one thing really, and that's what makes it all difficult really overall.
Yeah, completely. I think
much more complicated.
Yeah, and I guess that probably ties back to obviously a bit of that demand for the person-centered approach, doesn't it?
Indeed, indeed, the holistic approach. Yes, indeed.
I think I think the complexity of it has been really borne out. I mean, when we look at the whole issue of, let's say, health inequalities, we know there's been a lot of data published recently in the media about the differentials in terms of the impact of COVID on people from Black and minority ethnic backgrounds.
That's a big thing. Yes.
And what's quite interesting about it is that because all the available research suggests that there's not necessarily any genetic reason why people from those backgrounds might, have worse health outcomes. It might, A, they might be at greater risk of contracting the disease, and B, the outcomes that they have might be, it might have a much worse impact on them. But what a lot of the available,
it could be vitamin deficiency. Actually, that's what they said recently.
I think, I think there's still a lot of conjecture about what is at the root of these differentials. But I mean, there is stuff, for example, it might be that people from those backgrounds, it might be the fact that they live in multi-generational households, for example, which means that the potential for it to be spread is much higher.
A lot bigger, isn't it? Yeah.
Yeah, of course. And then there's other things as well, is that there are issues around institutional racism and things like that, whereby one of the things that's been discovered is very often people from the BAME backgrounds have been less willing to engage with NHS services, for example, and they've only presented when their symptoms have become extremely severe, and for that reason it might be that that they're not necessarily getting the support that they need early on and the early intervention, which might slow down and prevent the disease from progressing. And again, there's a whole other range of things, like we know that during lockdown, a lot of us, we were fortunate enough to be able to work from home for a time, which is still partly the case now. Whereas if you think about somebody who might be working in let's say somebody who works on a 0 hours contract, and we know, for example, people from BME backgrounds, a lot of those people work in the NHS, a lot of them work in social care, a lot of them work in industries which are 0 hours contracts, which means they're likely, bus drivers and so on and so forth, they're likely to come into contact with people who may well be transmitting COVID. So again, it's when we're looking at these things that there's a huge amount of complexity involved.
And then we've got the big north and south divide, haven't we?
Absolutely, absolutely. And I think as well, I mean, personally, there's been a lot of criticism of government and government policy. And I was watching an interesting item on the news just recently, and it was about the differences in COVID outcomes for people from different minority ethnic backgrounds. And one of the things that was being said, they were giving some examples of some bus drivers in London, who initially, when the COVID outbreak first hit the UK, they were basically driving round and taking fares off people without having any personal protective equipment. So it meant that those people weren't adequately protected. Likewise, you might recall, again, which was quite controversial at the start of the COVID outbreak in this country, there was a lot of frontline health workers who were making large noises about the fact that they didn't have the personal protective equipment they needed to keep themselves safe, and there was a delay in that.
I think we are a little bit digressive from the integration. However, in terms of the impact of COVID on the BME, I can say that apart from COVID, all other diseases have got socio-economic background of people or geographical area as the main factor. Because even if you look at cancer and all that, if you look at northeast of England, it's far worse than Thames Valley in the south. So that clearly shows that the socio-economic issues are key. If you look at the COVID, for instance, if you look at the frontline workers in the NHS, people who are doing cleaning and all that, people who are likely to be impacted by the disease are more or less from the BNE side, because 90% of the cleaners there are from that group. So that shows.
Elvis, do you think that justifies the North and South debate then?
No, it's part of it generally. So we've got a North and South divide, and then we've got internal divide. If you come to the North, there are differences in terms of socio-economic background. If you take the whole country together, the South are better than the North. Why? Because economically, the North are more deprived than the South.
Right? Absolutely.
And then when you come locally, we deal locally, and some are in the working class people, where the majority of the BME belong, are more likely to be impacted more than those in the upper class, even within the North. So you could see above the North and South divide, internally, we've also got differences, which all plays down to the socioeconomic background.
Right. So I think what you're saying, Elvis, which I totally agree with, based on all the information that we've got available to us, I think we can look at health inequalities from the perspective of gender. We can look at it from the perspective of ethnicity. We can, the main thing that always stands out consistently, even in the government's own data, is the difference between it's the socio-economic differences that ultimately seem to be the most significant driving factor, driving what we would determine health inequalities to be. And again, it's quite interesting because a couple of years ago, there was a researcher at the University of Manchester, and what the researcher did was he got all the data on life expectancy in Manchester. And what he did was he basically plotted life expectancy in different parts of Manchester based on the Metrolink network, and it was really stark when you actually see the differences, where I think one of the differences is between somebody who lives in Rochdale town centre, their life expectancy is it might be 73 or something like that, whereas somebody who lives near to Milne Row, which is about 3 or 4 stops down the line and is a little bit more greener and wealthier, the difference in life expectancy is something like 7 or 8 years, which is huge, and that's both for men and for women. So even within Greater Manchester and within the region that we live in, you can see massive differences in life expectancy between somebody who lives in the inner city area and somebody who lives in somewhere leafy like Hale Barnes or somewhere. The differences are absolutely massive.
What's unfortunate, is that it's become very much a political debate now. It's called ping pong and having discussions and arguments about who has the right answer for these solutions, and that's very, very unfortunate.
Rather than focusing on just getting to it.
Where that has become a political argument rather than touching on the main issue. It's scoring points.
Well, my argument is, if you look at all the research by people like Michael Marmot, he talks about, who's the public health guru, who's been one of the key drivers behind government public health policy. He's been saying that ultimately health inequalities are driven by wider socio-economic inequalities, and the fact that the reason that somebody might choose to smoke, for example, is they might be very fatalistic and think, well, I haven't got a lot of money, I live in poor quality housing, I've got to have a couple of pleasures in my life, haven't I? So he talks about the causes of causes, and it is hugely political because ultimately, again, if you think about people like Danny Danny Dorling and you know, Michael Marmot, I think what they're saying very clear. They argue for the fact that health inequalities are ultimately driven by socio-economic inequalities.
But don't you think it's becoming divisive though? That's the main issue.
Don't I think what? Sorry.
It's becoming divisive.
Well, it is. Yeah, it is divisive from the perspective that there are different viewpoints in terms of what the solutions are, what the root causes are.
I think as well, obviously, you're seeing a bit of that at the moment with what's just happened with Manchester, is them kind of balancing that economy and one side of health being, you know, mental health, you know, you know, that kind of element of it versus physical health in terms of like COVID and the spread of that. So I know what you mean. It can become very political and it turns into a kind of, you're choosing which is more valuable when how can you really say one is more valuable than another?
Yeah, because at the end of the day, if you think about the impact of, you know, people were talking on the news last night, I was watching the local news and they were talking about the, you know, they've got relatives, for example, who are in care homes with dementia and they've not been able to have that contact with them. And as a result of them not being able to have that contact with them, you know, they've seen them deteriorate and go really badly downhill. So think about the term harm in the wider context. You know, somebody who works in the hospitality industry who hasn't been able to secure an income for months and their future's uncertain. If you think about the impact on their physical health, because they can't afford food, they can't afford rent, they can't afford to pay for the housing, they might not be able to afford, you know, food, drink, holiday, whatever you say. So yeah, I think it's something that it's a hugely, the whole thing is huge political.
Very cyclical, isn't it?
Yes, indeed.
All right, a quick one. In terms, back to the integration.
Yeah.
If you look at secondary care, integrated work is actually working perfect. For example, within secondary care. For instance, if a patient is diagnosed from the GP with a cancer of any stage, we have the surgical oncologist will be there, the radiation oncologist will be there, the medical oncologist will be there, the palliative care specialist will be there, and then the nurses, Macmillan, will have a role. So you could see that they are working as a team. However, when it comes to social care, right, even though NICE has recommended, NICE has actually seen with the NICE report that the social care is fragmented and people find it quite hard to assess, right? And then people are being treated as a collection of conditions or symptoms rather than the whole person. So if an older person has got a need, maybe a particular, maybe a dementia, they look at that dementia alone and treat it and leave the rest. However, NICE has actually made it quite clear that healthcare practitioners, managers, and commissioners are all supposed to work together, right? But this is not working, right? No. Because there should be a care coordinator who should lead the assessment process, liaise and work with all health and social care services.
That's right.
Including those provided by voluntary and community sector. But this is not working.
You're absolutely right, Elvis, and I totally agree with you, because I think that one of the things that's really been, one of the things that's probably been missing in recent years, and I think the general thinking behind integration was it was going to result in a lot of new professions that were going to come into play, whereby rather than somebody, I know it's happened with the learning disability nursing program, for example. Learning disability nurses are actually trained in nursing and in social work, so they do it like a joint qualification. And really, for me, a lot of the key stuff around doing assessments of need around people, the role of that currently falls on local authorities. And likewise, if you think about children, where they've got to identify, you know, a child in need, a child at risk of significant harm, the main duty for actually doing that falls with local authorities, and mainly the professions that is around is social work. But the danger is those social workers don't necessarily have the same degree of expertise in looking at health conditions. So really, I think right from the outset, with again, when we're thinking about primary care, we need to, and you know, all the stuff to do with assessment and care planning, it needs to be jointly delivered. It needs to be jointly commissioned, jointly funded, in order for it to work. You know, as somebody who's worked in health and social care, I've always seen those divisions there. And you know, if you look at the Care Quality Commission, all the reports that they've done, you know, they're still saying and banging on now, saying that integration is not happening. It needs to happen because people are not getting the outcomes that they need. People are falling through gaps. It's still happening today. And something else I think is worth thinking about. Again, it was you talked about secondary care. The big changes that's happening at the moment with primary care is that through you might have heard of these new things called primary care networks, and the way primary care networks are going to be working is that GP surgeries are now going to have additional professionals attached to them. So every GP surgery is now going to have like a pharmacist. They will have a pharmacist. They're going to also have a social prescribing link worker. They're going to have a community paramedic, and they're going to have a physiotherapist as well. And the idea of having those people working in primary care is that those people are going to be able to diagnose and prescribe. So what that's doing is that's about increasing accessibility to primary care, and also trying to think more creatively and innovatively in terms of solutions. So to give you an example of how they're looking at that working is, you might have somebody who goes to a GP who's presenting with symptoms of depression because, let's say, they've gone through a breakup of marriage or something like that, and they're quite lonely, and it might be that a social prescription would be more appropriate. So the person could be referred to self-help groups, or let's say walking football groups, or something like that, rather than putting them on antidepressants for 6 months, which, you know, always take so many weeks to work. So I think the approaches that are being looked at by the government are, you know, I think they're going in the right direction. But I think to some extent there's still a little bit of resistance amongst the professionals, and I think because you've got different professional bodies as well, there's all sorts of barriers that are still getting in the way, and there's big cultural changes that are happening, and still
that's a big problem, because in primary care, in social care, people are not looked at holistically. And I also begin to ask myself, our learners we are training, they are not pharmacists, they are not physio, they are not occupational therapy, they are not mental health specialists, they are not social workers, they are not psychiatrists. And so how do we carve a niche for them? Because most often the question begin to pop up. Oh, Elvis, so when I finish my BSc of integrated care, what do I do? We should be able to carve a niche for them. So if integration is actually working and people are assessed holistically, then our learners will have a place. So probably it all boils down to implementation of integration, because on paper, everything is there, and NICE has given it guidelines as what needs to happen. So probably it's the implementation that is the issue now.
Yeah, I mean, we know, for example, you know, if you think about, you know, you referred to NICE, for example, and we know the Care Quality Commission as well. The role of the Care Quality Commission was predated. The Care Quality Commission was predated by an organisation called CSCI, Commission for Social Care Inspection. And in the wake of the Francis report, and obviously the events that happened at Winterbourne View, the Care Quality Commission took over the role as the the lead regulatory body for health and social care in Britain, and the standards that they have, the fundamental standards that they have, which apply to all of us. Basically, it doesn't matter whether you're using a GP surgery, using a care home or home care, you know, you should have this, you should expect the same level of standards. And obviously one of the key things behind those standards is that you have an assessment of your needs carried out, that care is delivered to you that is done in a person-centered way, that you're treated with dignity and respect, you get the advice, the support, the input that you need to ensure that you do have a good experience, you have good quality care. And I think increasingly as well with children and young people services, you know, the Ofsted frameworks have been very much, you know, in line with that sort of integrated, holistic, person-centered and child-centered way of looking at people who might be potentially coming into contact with services. And I think, yeah, some of the journey towards integration has happened, but there's still a long way to go, a hell of a long way to go. And you know, it's going to be an ongoing battle for us because, like you said, Elvis, a lot of our students who are doing an integrated pathway, you know, the ones, some are obviously choosing after they've done the HNC to go on and do a nursing degree or a social work degree or an allied health profession. Some of them are choosing to stay on and do a master's. So we've had people who've done the BA, who've gone on to do a master's in nursing, masters in social work, and some have gone on into research roles. And obviously there's lots and lots of other potential opportunities out there for working in roles like commissioning, registered manager roles. So
yeah,
I think
recently one of our learners has gone into commissioning, which is a very good news for us.
Of course it is, yeah.
Can I just kind of interject there, because that probably ties in quite nicely with one of the questions we've got, and then we'll just kind of, I'll ask this question and I'll pass back to you, Adam and team, just to kind of wrap up as we go, because I think this looks like the last of the students' questions we've had through, which again talks about kind of the pathways that you can use courses like this for. So can you do a health and social care course in college and then be a medical doctor, or would you need to change your course in uni for medicine? So I think it's a bit on entry requirements there for an end result in medicine.
Yeah, I mean, I think if you wanted to do something like that, I mean, that's a very, very specialist profession, which does have very, you know, very strict and very, very specific entry requirements. I mean, it would be fair to say that the programs that we do, you know, if somebody was maybe looking to do that, then it might be that if they've done, say, level 3 programs, then they might choose an alternative pathway, like doing an access. It may be that through the you know, doing something like the HNC healthcare practice that we do, that would give them a good understanding and awareness of the you know,
sector, probably more.
The sector, yeah, which I think is often something that's very, very missing. Whereas if you go down and train to be a doctor, you go and train to be you don't necessarily have that. You don't necessarily have that overview of the sector and the policies that underpin the sector and how the sector is evolving, and some of the current issues that we're currently dealing with, like the health inequalities, like, you know, the population health approaches, which ultimately you know, are driving where we should be at. So yeah, I think that's, if I was going to give a definitive answer, I think, yeah, I think there are opportunities for doing something like the HNC to give somebody a you know, that opportunity to then focus more specifically. Obviously you can't become a doctor at UCEN Manchester at the moment. That's something we're working on, but you know, what we can do is we can, like being a nurse or a social worker, whatever else is, we can give people the stepping stones that will enable them to get there. And we think to
add a bit to that, I know people have gone through the access route to do medicine, others have gone through the BTech, because Distinction Star It's ranked as an A in the as an A level, right? So however, it's not, if you want to go to the Russell groups, then they are so strict on physics, chemistry, and another test subject. But apart from the Russell groups, who are not eager to get people with BTech qualifications, there are other universities where you can get your BTech qualification, have your distinctions, and then you are equally having the chance. Besides, our learners who have gone through the health and social care system, some of them with a lot of experience, are bound to succeed if they're able to get their distinctions in interview, because they know what they are doing, compared to a fresh A-level person who has no clue at all about anything about care. Right? So people have gone through that, not in UCEN, because I've not been UCEN for long, but I know people with distinctions, 3 distinctions, that will be able to go on to do medicine.
Yeah, and I guess what you're saying there is it's more about, if you're going to do a BTech or a HNC, it's the benefit there is that it's got that practicality built into it. So you're getting, so you got that real world experience is almost your step up, isn't it?
Yeah.
All right, well, I think that's the last of our questions. It's been a really fantastic debate to listen into, and yeah, very topical as well. So Adam, Karen, Marie and Elvis, I don't know if you've got any final comments you want to add before Amelia wraps up.
No, I'm fine.
No, fine, thank you.
I would only say that obviously I'd finish off by saying that, you know, obviously for anybody who is interested in studying with us, either on childhood and youth studies program or health and social care program, you know, we are obviously in a position where we're looking to develop our facilities, because we've got this huge campus redesign ongoing at the moment, so our practical facilities are going to be really sort of state of the art and bang up to date. And I think it would also be fair to say that one of the things that our validating partners, universities and awarding bodies always comment on positively is the profile of the people who teach on the programs, in that, you know, we're all people who are industry experienced, industry qualified, you know, we're all experts in our own areas, and like I said, that is something that I think we're always greatly complimented on by external examiners and validating partners. And, you know, to me, that's one of the big selling points, unique selling points that we've got, as well as being the fact that Manchester is really, you know, leading the way in terms of what's happening in health and social care across the country, because obviously we've got devolution, and we're seen as being the testing ground for the government's devolution agenda. And now, obviously, because of the nature of the fact that although we do have very poor health outcomes, we're hoping that a lot of the policies and things that are going to be happening in this part of the world are going to be, you know, innovative and hopefully lead the way in terms of what happens elsewhere. So watch this space, so to speak.
The space of the NHS as well.
One more word? Can I add one more word?
Yes, of course you can.
We've expanded our provision with a lot of pathways. Now we've got the integrated health and social care pathway. We've got the nursing pathway, we've got health promotion pathway, and other pathways. So we've got a lot of areas that people who come on our HNC and HND program can go on. So this is something that I think is unique with UCEN Manchester.
Yeah.
That's a really good point.
And obviously there's that flexibility that people, you know, people can just come and do 1 year and do an HNC, for example, and use that as a stepping stone to get onto a degree program in, you know, an area that they want to specialise in. Or they can obviously stay with us for the full 3 years and do a BA in childhood and youth studies or in integrated health and social care. So I think, again, that's something that students really like. They like that flexibility. So there's still people who, even when they come to us, are saying, well, I've not quite made up my mind what I want to do yet. But normally, you know, during the course of the studies with us, that, you know, it tends to clarify and crystallise where they want to go on their professional journey. And obviously we provide as much support and advice that we can to help them in choosing a career that's right for them ultimately.
Brilliant. Thank you very much, and thank you all for joining us this evening. We do have further events, including the Future You Student Support drop-in running until Thursday. So please visit our website. It's ucenmanchester.ac.uk/online open days to register for any more sessions. If you'd like to apply to UCEN Manchester for 2021, please just again visit the website to find your future course and hit apply now. You can also find us on UCAS by searching UCEN Manchester. Again, thank you for joining us. Thank you all guys for this amazing presentation, and I hope you all have a lovely evening.
Thank you.
Thank you.